Thank you. I would like to start with thanking the organizers to invite me for the fourth time to give a talk. So that's nice to continue the story of the company I'm representing, which is not really Pharmaida, it's MydaTech, which is the actually mother company in Oxford, UK. If I could get the first slide, then that would be helpful. So I assume I get extra time for this. Right, there we are. So I would like just to put our technology in perspective, kind of an historical overview. Liposomes as drug carriers are old technology. I remember being at Roche that we worked with liposomes as drug carriers a long time ago, and actually it's already started in the 70s. But it was obviously not called nanotechnology, but it was liposome carrying. And liposomes got improved by pegylation to increase residence time in blood, and other tricks. Polymers were introduced, etc. As you know, the whole history, new technologies came on board. And in 2012, we proceeded with the first in-human study with very small gold nanoparticles in human volunteers. And I presented the data of that study last year and the year before that. MydaTech's technology is based on actually gold core nanoparticles. They are very, very small. We make them in a one-step self-assembling process, which is common for making gold nanoparticles. And they are glycan-coated, and that's basically the invention that is the basis of our company. They are small, 2 to 5 nanometers. Actually, the actual core of the gold is not more than 1.6, 1.7 nanometers in diameter. And it can carry a number of drugs, actually by using the property of binding substances to gold via sulfur bonds. And in this case, we have this glycan corona, or glucose molecules here, but you can replace any of those with another product, basically. So you have a very versatile system to work with. And besides the work on the diabetes program that I reported on previously, where we used the nanoparticles as carriers for insulin and give them as a transbuccal film, we now focusing more and more on oncology for obvious reasons. And our goals in our program are twofold. We want to offer combination therapy, so several drugs on one nanoparticle, and in addition to that, give them these nanoparticles targeting ligands, so that you have actually the best possible combination per particle. Our small nanoparticles mean that, of course, the surface area is quite big, and as you know, about 1 gram of 5 nanometer gold nanoparticles have about more than 200 square meters surface. So it's a huge surface that you can cover with drugs and with targeting ligands or peptides. Our standard nanoparticles have about 100 gold atoms in the core, so it's more like a single crystal, of gold. And on the outside, we have about 40 binding sites. So in principle, you can bind 40 different molecules on one single nanoparticle. And what we have today, we made a chemistry program to come to a kind of a standard where we can add any substance and on the corona, and we are now focusing on 4 different compounds per nanoparticle as the standard approach to combination therapy. We do this by what we call orthogonal coupling. Actually, we cover the nanoparticles with a number of predefined ligands that allow binding of molecules with several kind of chemistries. For instance, by amide coupling, which we frequently use, you can do an hydrazone coupling, which also allows to have a pH-dependent release inside cells. We very often use now click chemistry to easily get compounds with a ketone function on the nanoparticle, and we can also directly link sulfonamides or isothiocyanides as potential chemistry linkage. The targeted therapy comes on top of that by having this versatile 4-in-1 nanoparticles, where we not only couple the chemotherapeutic drugs or other substances, but also tumor targeting molecules. And simple ones like folic acid, lactose, glucose, and there are also more complicated ones, Fab fragments, nanobodies, aptamers, pieces of RNA, you call it peptide ligands. Basically, you can attach any of those compounds to the nanoparticle. And they all are covalently linked, but you can also non-covalently link peptides or proteins to the nanoparticles to give them certain properties. That is the one part of active or passive targeting, but you can also add to that other specific targetings by injections in the tumor or close to the tumor, or also by giving systemically these nanoparticles. These nanoparticles are paramagnetic, so once you have systemically distributed your nanoparticles in certain tissues and in the tumor, you can then very locally try to radiate or put magnetic waves in the site of the tumor, so to have additional targeting from that procedure. So this is a kind of a classical standard nanoparticle that we're currently using in our oncology work, where we classically bind 2 compounds and use 2 targeting principles. In this case, you see folic acid and glucose. Glucose is also tumor targeting in a sense because of the Warburg effect that tumors like to take up glucose for the energy, and that's what we also observe when adding glucose to these nanoparticles. So that is the kind of multifunctional nanomedicines that we are building and working with. And we selected to work on orphan indications for a number of reasons you all may understand, and we picked 3: ovarian cancer, hepatocellular carcinoma, and brain cancer, but primarily glioblastoma. All of them are about in the same range of incidence per year in US plus Europe, so around of 80,000 new cases per year. Our portfolio is the following. In ovarian carcinoma, that was the first actual program that was started, supported by a CDI grant in Spain, where we tried various combinations of drugs, platinum-4 analogs, docetaxel and methotrexate or pemetrexate, which are folic acid analogs. Some of them need to be modified so that you have an analog of the drug. In some cases, you can directly couple the drug to the ligands that are on the nanoparticle. We use as tumor targeting, in the case of ovarian carcinoma, folic acid primarily. As you know, folic acid will bind to the folic acid receptor, which is highly overexpressed in ovarian carcinoma cells. Actually, over 95% of ovarian carcinoma cells do overexpress the folic acid receptor alpha. We have used a number of these compounds to establish proof of mechanism of the anti-tumor effect and the targeting in xenotransplanted mice, but I have no time to go into detail there. Hepatocellular carcinoma, there we use the property of these cells having the same kind of a receptor as hepatocytes, which is the asialoglycoprotein receptor. This receptor recognizes, for instance, lactose sugars will only go to that particular receptor, and that's the targeting effect that we are looking for, and I will show you just in a minute an example how effective this works. At this point, we are making several leads, adding a number of compounds, but primarily platinum compounds, as well as sorafenib, which is the only approved drug for the treatment of HCC. And in glioblastoma, we're working together with the Open University in Oxford and with the Dana-Farber Institute in Boston. And there we are now in first instance looking for nanoparticles that have an improved crossing potential for crossing the blood-brain barrier. Just as an illustration of tissue distribution, if you take a nanoparticle of that size, very small, 2-3 nanometers, and you cover that with glucose, you will find it in practically all tissues and all cells. It goes actually in the interstitial water quite rapidly. If you put it in IV, within a few minutes, it is outside of the blood vessels. It's all of the place basically, and 5-10 minutes later, it's already peed out by mice if you inject it IV. But you will see nanoparticles in all the major organs. If you now replace glucose with lactose, it is a dramatic difference. Lactose nanoparticles you will see nowhere except in the liver. And remember, this is a very small nanoparticle. It will not necessarily be taken up by the liver because of its size. It's just because of this property of having lactose at the outside. And this is actually what we're going to use for targeting hepatocellular carcinoma cells. The blood-brain barrier, it has been discussed this morning already extensively. There are a number of possibilities for compounds to cross that blood-brain barrier, although it's very complicated and not very effective. It's all known that small molecules lower than 500 Daltons and lipophilic will cross, and that is the lipophilic transcellular pathway. In theory, you could also have a paracellular pathway going through the tight junctions, but they are really tight in the blood-brain barrier, as you all know. You can use eventually transport proteins like transferrins that sometimes bring things across the blood-brain barrier, or at least across the first endothelial cell layer. You can have receptor-mediated transcytosis, and you can have absorptive transcytosis, and sometimes you can also use efflux mechanism to get something in. Now we have extensively looked at that in collaboration with Open University primarily to look in human endothelial cells as well as biopsies, brain biopsies of patients, and in three-dimensional structures where we mimic kind of the blood-brain barrier by having an endothelial cell layer followed by interstitial tissue and astrocytes. In those systems, we could demonstrate that our nanoparticles, several of those, can cross the blood-brain barrier very efficiently. They don't use the paracellular water-soluble pathway, but they go quite rapidly through the endothelial cells. We have indications that they can use the transcellular lipophilic pathway. That is what people call kind of snorkeling, that nanoparticles can have some kind of a interaction and fusing with lipid bilayers, quickly moving through the cytoplasm. We observe that in our histology sections. We also have demonstrated that we see receptor-mediated transcytosis in the endothelial cells of the brain, as well as absorptive transcytosis, which we for instance, observe if we put our GNP insulin or insulin nanoparticles on endothelial cells, they very rapidly go through the endothelial cells and end up in the interstitium space. So these are the systems that we know, and we are now just about to put chemotherapeutics on there and start our first in vivo studies with these small nanoparticles in the different indications of ovarian carcinoma, hepatocellular carcinoma, and glioblastoma. Thank you for your attention.
Thank you for the fascinating presentation, especially with lactose. It was very interesting. And now the floor